Thank you very much. So if the question is which are the most relevant biomarkers to test in the chemo-free era, I can say that the answer is very, very simple, because the biomarkers to test are more or less always the same, like in the chemo-immunotherapy era. Basically test for p53 disruption, both p53 mutation and deletion chromosome 17p, and the mutational status of immunoglobulin, the so-called IGVH mutation. Here in Aviano, I run a laboratory that provide a complete diagnostic, prognostic assessment for oncohematological diseases, including CLL. We started doing so kind of 20 years ago. So for CLL, we have a first-hand experience regarding the passages from the chemoimmunotherapy era and the chemo-free era, that is the era of nowadays. Like 10 years ago, when the chemotherapy was still an option, a valid therapeutic option for CLL, was important to have evaluation of p53 disruption and afterward the mutational status immunoglobulin to choose between chemotherapy and the emerging target therapy. In particular, of course, chemotherapy was reserved to patients without p53 disruption and with a mutated immunoglobulin gene status. All the other patients were driven toward the new target drugs that at the time was ibrutinib as a BTK inhibitors and the PI3 kinase inhibitor idelalisib. When we enter the chemo-free era, that was about 5, 6, 7 years ago, so chemotherapy was virtually no longer prescribed. The first thing we thought was, okay, biomarkers are no longer needed. However, it's not exactly in this way. And the guidelines still advise to have information regarding p53 disruption and mutational status immunoglobulin. Now, to choose between a continuative therapy or a fixed duration therapy. What is usually done is that patients with p53 disruption or an unmutated IGVH status are treated continuously with BTK inhibitors. And patients without p53 disruption and with a mutated IGVH status are better addressed toward fixed therapies with BCL2 inhibitors. Of course, this without considering patient-related factors, comorbidities, and so that may change the choice between upon a biomarker-driven therapy or not. Another important thing that has to be stressed regarding p53 is that the testing has to be done before the first-line therapy, and especially if negative, to redone before any change of therapy. This because p53 status may be somewhat modified during the course of the therapy because of the occurrence of clonal evolution. This is not the case of the mutational status immunoglobulin, that is always the same, not changing during the course of the disease. So there is no reason to test the immunoglobulin status more than once, with I would say a single exception, that is the Richter syndrome evolution. Here, the retesting of immunoglobulin is done to check whether the lymphoma that is derived from CLL is or is not clonally related to CLL. If not clonally related, the prognosis is better, and the lymphoma has to be considered a de novo lymphoma, and perhaps the therapeutic approach is changing. Remaining in the field of Richter syndrome, other biomarkers that have to be mentioned and that may predict the Richter syndrome evolution, the Richter syndrome development, are the presence of trisomy 12, the presence of Notch1 mutation, and the presence of a specific B-cell receptor, that is the so-called subset 8. These are information that are useful to know in order to follow better, those patients that are at risk of Richter syndrome evolution. I close by mentioning, among the other biomarkers that are presently available, the possibility to investigate the mutation of BTK and the mutation of PLC gamma 2, that is the molecule downstream BTK in the B-cell receptor pathway. These tests have to be done in patient, of course, in treatment with BTK inhibitors, and that are progressing under therapy. Although these testing are not strictly included in the guidelines, these mutations are found in about 2/3 of progressing patients and may inform about the incipient progression of the patient. What I want to stress in this regard is the need to look for a complete panel of BTK mutation, not only look for the most frequent single cysteine mutation that are usually investigated. This because the reason is that different mutation may help to choose better the second generation BTK inhibitor to use. In fact, some of these new inhibitors, without entering into detail, are effective also in the presence of specific BTK mutation, but are not effective in the presence of others. Therefore, it's important, in this case, to have an overall picture of this mutation to better select the drugs to use. I say that I can stop here by underscoring again the relevance of an integration between clinics and laboratory in the management of CLL patients.